Hi, my name is Jenifer Lightdale. I'm an Associate Editor for Gastrointestinal Endoscopy, and it is a great pleasure to be here today with Richard Wong to discuss his article entitled Immediate Unprepped Hydroflush Colonoscopy for Severe Lower GI Bleeding, a Feasibility Study.
Well, thank you very much. It's a pleasure being here.
Thanks, Rich. Thanks. So tell us a little bit about what brought you to this study. Give us some background.
Right.
What made you start thinking about this?
Well, our focus is actually on patients in the intensive care unit who have severe acute lower GI bleeding. It's these patients that are nowadays given the urgent colonoscopy and the rapid bowel prep, which consists of a large volume of polyethylene glycol-based solutions. And up to 50% of these patients may need NG tubes. And patients generally don't like NG tubes. There's a delay in endoscopy because of the bowel preparation. And in actual clinical practice, many patients are actually referred for radiology as opposed to endoscopy as the first-line test. So that's what really got us into looking at this is, can we do immediate colonoscopy without the oral bowel prep? So
and
that's
of course,
the question we had.
Radiology often can't find the source, right?
Exactly. Radiology often can't find the source. They send the patients back upstairs. It's very frustrating for the clinician because no source is identified. For radiology to be effective, the patient has to have active bleeding at the time of the radiology study. Otherwise, it's a negative study.
Right, and we're more apt to actually be able to locate the bleeding
Exactly.
even if it isn't gushing.
Right.
So tell us about how the hydroflush technique works.
Well, the hydroflush technique works. It's a technique to cleanse the colon of stool and blood. Primarily, it's actually blood and blood clots. That's what we're trying to define. And what we found is in patients with a lot of blood loss, like in these ICU patients, they have the blood acts as a cathartic and the blood pushes the stool out distally. So sometimes it can actually assist us because we find what we call a demarcation zone between proximal to the bleeding lesion, we see brown stool, and distal to the bleeding lesion, we see the blood.
Of course.
So it actually helps us. It actually helps us, particularly in left-sided lesions. So the hydroflush technique works by we give these patients 3 tap water enemas, 1 liter at a time, 20 minutes apart. So that takes about an hour.
Okay.
Not a drop of Go Lightly or polyethylene glycol touches their lips.
Or an NG tube.
Or an NG tube,
right.
Nothing like that. These patients are resuscitated in a standard way, and then we proceed straight after the 3 tap water enemas after their resuscitation with the immediate colonoscopy. During the colonoscopy, we use the modern kind of power wash techniques, the power jet irrigators that we have now. We also use these mechanical suction devices through the endoscope if needed. And once we find the bleeding site, we are able to identify it, localize it, treat it, and tattoo it, just in case the patient may need surgery at the end and the surgeon can know where the bleeding lesion is.
Fantastic. Sounds very simple.
Well.
So tell us a little bit about the differences between an immediate unprepped hydroflush colonoscopy and also how we do the normal colonoscopy where we've actually prepped the patient. So there's the delay.
Right. The normal colonoscopy, there is the delay, and oftentimes it can be many hours. And what we wanted to do was to bring the time from when the patient was admitted to the colonoscopy so that we can better identify the bleeding site and the bleeding lesion. And even if the patient's not actively bleeding, we can find stigmata of bleeding, like a visible vessel, like an adherent clot, something like that. The standard bowel prep, the urgent colonoscopy, is in studies that have been published, the median volume they need is 5.5 liters of polyethylene glycol PEG-based solutions.
Okay.
The range is 4 to 14 liters, and 50% of these patients need NG tube, which patients hate. They really don't like NG tubes. And patients are given 1 liter of solution every 30 to 45 minutes until it's fairly clear, and then they do it. And that whole process can take many hours.
So delay, patient satisfaction, they're happier. Yeah.
Exactly. What we found is that patients don't like NG tubes. Patients generally don't like being given 4 to 14 liters of solution. And patients prefer the 3 1-liter tap water enemas. As soon as they're resuscitated, we do the colonoscopy. And in none of the patients that we had in the study did we need to repeat the colonoscopy. We had adequate bowel prep.
Okay. And how about detection of the lesions? Do you think you're as sensitive finding the lesions?
I think so. At least in our feasibility study, we looked at 12 patients and 13 procedures. Our our rate of endoscopic therapy was about 39%, which is a little bit higher actually than some of the published studies. But again, it's a small study. But yeah, I think we're in the right ballpark of picking up lesions. I think larger studies are needed to really see how this compares to standard of care.
You characterized the work as a feasibility study.
Yeah.
When you started it, did you think it was going to work?
We weren't sure. In fact, we weren't sure whether it was going to work because we were concerned that we may not actually see the bleeding lesion. So we wanted to. We really weren't sure. But we know that the availability now of these power jet washers are much better than what we used to use, which are 60cc syringes. We used to load up 60cc syringes of water and flush it manually, and that would not work. Takes forever.
Carpal tunnel syndrome.
Carpal tunnel syndrome, exactly. And we used to utilize just the endoscope suction, which is very weak and would frequently get clogged up by blood clots, and that wouldn't work. So we wanted to see. So we weren't sure is the answer when we first started.
Okay. So basically, would you say the benefits of using this hydroflush technique as opposed to traditional options is really going to be something that drives this in the future, is becoming the way we all start to treat these patients?
Well, I think so. I think time will tell. I think we need larger prospective studies. This is just a feasibility study. We need larger prospective studies to really find out whether it is useful or not. I think potentially it can decrease length of stay both in the intensive care unit and also in the overall length of stay. It can decrease time from admission to the colonoscopy and potentially increase your diagnostic yield of finding a bleeding lesion and finding the site.
I think that is exciting.
I think that is very exciting because many of these patients, if it's a common scenario is that we go in there and all we find is pan-diverticulosis. There's diverticulosis across the right colon, left colon. It's a patient clinically with lower GI bleeding. We've done the EGD and that's negative. The patient keeps on rebleeding. You do TAC cell scans. The TAC cell scans are negative. The surgeon's there with his knife, and what's he going to do? The surgeon in that instance generally does what they call a blind colectomy or a subtotal colectomy. We're hoping, we propose that if we can find the site and we can at least localize it, try endoscopic therapy, and tattoo it, and even if it doesn't work, the surgeon may be able to do segmental colectomy as opposed to a subtotal colectomy.
Well, sounds interesting, and I'm going to look forward to more evidence that's going to drive this practice.
Thanks very much. Thank you for interviewing me.